Good morning. I just saw that some people in the audience might be bored or asleep because nobody was saying good morning or replying to the doctor. So let's bring some energy to the room. And you're going to, I don't have, yes, here's the sound. So I think that now everybody's awake. Next time I come to India, I promise that I will make a video with my team dancing some Bollywood sounds, okay? Because actually I must confess that I'm a big fan of what happened in Bollywood. So thank you very much for this opportunity. Thank you to the organization of the Congress. This is my office. This is where I work every day. That's my sister. She's not my sibling. She's not an identical sister. We look pretty much identical, but she's older than me. She do all the prosto in the clinic, so some of the works you will see this morning, it's due to her help. This is where I spent practically most part of my week. This is a university. I'm director of the program in periodontics. This is the small team. In total, we're 23. The first one on the right of the slide is Dr. Jose Enar. He's the chairman of the department and director of the program. I'm in the middle. I'm also director of the program. And the woman in the left is Dr. Cristina Valles, who is, I'm very proud to have her as part of the team because she trained with me. I started as a teacher a long time ago, and now she's the coordinator of research in our department. We recently received, around 5 years ago, the accreditation of the European Federation of Periodontology. We're the second master in perio in Spain to get it, so that's a lot of proudness for us. And it's making us work hard every day to keep that accreditation, not for our students only, but for what we feel inside. And because I have lots of free time, as you can see, between my office and between the university, I like to spend like every single minute of my life doing something. So since last June, I decided to I was elected as part of the board of the Spanish Society of Periodontology, SEPA, which is the #1 scientific society in Spain right now. It's being considered the #1 perio society in Europe right now due to the big work and the effort that we're doing to make periodontics for everybody and to spread it around the world, because we're also starting to move all around the world with our work. So I'm very happy to be in India. This is my first time in Mumbai. I've been very thankful for this, so namaste. And as we say in Spanish, hola Mumbai. So why are we here? We're here this morning because I was invited to talk a little bit about guided bone regeneration. I really like guided bone regeneration, but I'm not a big surgeon, so I'm not into huge cases. So what you will see are like small details of what it is guided bone regeneration. And why are we here also? It's because there are some disease in the oral cavity of the people in the world, and the most common ones are gingivitis and caries. Caries is present in pretty much most of the children of the world, and so is gingivitis. But periodontal disease is present in most of the adults of the world. 4 of each of 7 patients, every 4 of 7, have some sort of periodontal disease. And among that people, from 5 to 20%, depending on their geographical situation, will suffer from an advanced form of periodontal disease, right? And if we go to an index of oral conditions around the world, you will see that starting from 32, which is the country with the best oral conditions, to the highest or the worst oral condition, which will be 60. I'm sorry, ladies and gentlemen, because Spain is in 56, which is not a good number, but when it comes to India, you are on the number 60. So that means that we have a lot of disease around the world, and that disease will cause some situation, and that famous situation will be the tooth loss. And every time we lose a tooth, we will need to replace the teeth of our patients. And to replace the teeth, most of the time that represents a big challenge, and it's not easy. We need to understand the keys on how to solve the situations in order to provide our patients with the best solutions, right? And sometimes people think like, but what are the keys? I was trained in school to replace teeth. That's what they taught me. But how many of all the things that we learn in school we remember today? There are plenty of things that we forget. And one of them, which I believe is the most important one, it's biology. We need to understand biology. I gave a pre-course a couple of days ago, and I was asking the group, and I will ask now to raise your hand. How many of you have kids at home? How many of you have teenagers at home? Okay, so most of us are pretty much on the same decades of life. Some of us are younger, some of us are older, right? But when I was a kid, I had no possibility of choosing between 600 channels of TV. I had no opportunity to choose when I was going to watch something in particular, and I had no access to everything at every moment of my life. But the society has changed. If you ask your kids, you will see that whatever they want to watch, they grab an iPad, they grab a phone, and they start watching whatever the show they want and at the moment they want. And if you ask them about music, when I was a kid, my favorite artist came out with a record, and I had to wait for like 2 years before they came out with a new record. Music today, they come out with a song on Monday, and if you ask two people, next Monday, it's like, oh, it's so old-fashioned. Why are you playing that song? There's a new one, right? So the world is turning. Everything is going super fast. But it's biology going faster? Biology, it is what it is. We have to respect biology, and we have to understand biology. So if I do an extraction, what happens in the location of the extraction? What's happening in there? So there's some people that has wondered from a scientific point of view of what will happen inside the alveolus, and it's not something new. We have some articles that starting to appear in 1969 by Ambler, and there are some articles that were more recent by the group of Araújo and Linde, and that describe two processes, the intraalveolar processes and the extraalveolar processes. When it comes to the intraalveolar processes, we have to understand by the Ambler article that was written in 1969 that at the beginning, after the extraction, the first thing that will form is a clot, a blood clot. During the past of the hours, that clot will start changing, and we will start facing some granulation tissue inside the alveolus. And with the pass of the weeks, until we arrive until around 21 days, what we will see is that that granulation tissue and that clot will disappear completely, and we will end up finding some sort of an osteoid tissue inside the alveolus. And it's not only until 8 weeks after that we will find the final wound healing of the alveolus, right? This process was repeated on animals by Dr. Cardarapoli, who unfortunately passed away last year, and he did this on dogs. He took 9 mongrel dogs. They did endodontic treatment in lower premolars. They did hemisection of the distal root of the premolar, extracted the root, and moved flaps to close to get full closure of the alveolus. They sacrificed the dogs and took biopsies after 1, 3, 7, 14, 30 days, 2 months, 3 months, 4 months, and 6 months. By the end of this research project, what you can see is the chart that we have in here. On the left, on the day 1, as I said before by the article of Amler, we can see that the first day, 99.5% of the alveolus is a blood clot, and only 0.5% is granulation tissue. If you analyze the chart and you follow the lines from left to right, you will see that the tissues start changing from blood clot, and when we arrive to the first month, we will see that there is no more that clot inside, there is no more granulation tissue, we have some provisional connective tissue inside, and some mineralized reticular bone. And then by the end of the 6 months, we will see that all that blood clot, granulation tissue, and the provisional tissues are completely disappeared. And we have 15% of mineralized reticular bone and 85% of bone marrow, which is pretty much the natural bone of the maxillary and the mandible. So what does this mean? This means that in general, we need to wait around 6 months for the final healing of an alveolus. That doesn't mean we cannot do procedures like implant placement before, because we all know that we have early implant placement that could be performed after 6 to 8 weeks, and they will survive anyway. But if we want to know what happened inside the alveolus, this is what we really need to wait and what we really need to know. But when it comes to the extra alveolar process, it's a different concept. Why? Because we just follow what the histology of the inside of the alveolus was, but the outside, what's happening outside? Outside, we will use a reference, which is probably one of the most used references in the world, which is the Araújo and Linde article. They performed pretty much the same experiment that Cardarapoli did, but in this case, they sacrificed dogs at 1, 2, 4, and 8 weeks of healing. What did they find? This is a resume in the pictures of what happened following those 8 weeks. On the left, we can see the picture of the alveolus after the extraction. On the left side of the picture is the lingual bony wall, and in the right side of the picture is the buccal bony wall. As you see here, they're both preserved. Then when we go over the period of the 8 weeks, what you can see is that the buccal bony wall starts resorbing. And this resorption can achieve up to 30%. And this will be translated into a horizontal and a vertical loss of dimension. And why is that? We have to remember that the bony walls around a tooth are formed by bone and the other bone that we call bundle bone. And bundle bone, it's alive because of the periodontal ligament. So once we extract the tooth, we will lose that periodontal ligament. And bundle bone has no reason to be there because those fibers from periodontal ligaments that were attached into the bone will have to disappear. But the most important thing is that that periodontal ligament is full of vascularity. So as soon as we lose the periodontal ligament, we will lose the vascularity. And if you ask me, there's a reference here, the last one in the chart on the left is an article I presented in 2012 where we measured the thickness of the buccal bony wall. And as you see here, probably the mean in my article and the article by Broud, which are the most accurate in material and methods, more similar, you can see that the mean thickness of the buccal bony wall is around 1 millimeter. If I lose 0.5 millimeter because I lose the periodontal ligament, that 0.5 millimeter of bone, it's cortical bone. So it has practically no vascularization. So what will happen to that bone? It will resorb. And that's why we have the consequences of the article that was presented by Dr. Linde and Dr. Araújo. That's why we lose probably that part of the bone. And some other people have been aware of that, and it's been doing some research, and then we go to the systematic review performed by Dr. van der Vendel, and what they did is they reviewed the literature, they found 12 articles, they included them, where they evaluated the processes after 6 to 12 months after the extractions of anterior teeth, premolars, and molars. And they found out that the average reduction in width after an extraction is at 3.87 millimeters in mean. That means that in some cases it's going to be over 4 millimeters. They also say that the mean clinical height reduction is about 1.67 millimeters. And if we evaluate this in a radiographic, we will see that it's 1.53. And also, what is the amount of bone filling? We have to evaluate it from the apical to the coronal part of the alveolus. And they end up discovering that it's around 2.57 millimeters of bone filling. So for everybody in the audience, we have to have this in account, and we have to evaluate this and know it. Why? Because there's a lot of people doing immediate implants right now. We do the extraction, we place the implant, and we think that everything is going to go perfect. But it's not like that, because a lot of people is not aware of this resorption that might happen, and you will see it in some cases that I will show you in a few seconds. So the conclusion of this systematic review says that the clinical loss in width is greater than the loss in height. So be careful with the position of your implant. So now we understand biology. We know a little bit what happens inside of an alveolus after an extraction. And we have to replace those missing teeth from our patients. So we all know that today implants are considered the main indication to replace an absent tooth. Why? Because it's the less invasive treatment. We are not damaging other teeth to replace the missing tooth. So that's why we decided implants are probably the best. And the industry of implants is growing every day more and more. And it's estimated that by the year 2022, the American and European market for dental implants will be around $4.2 billion. That means that there are a lot of implants being placed around the world. Today, these are not accurate data. This is data obtained from implant companies that have provided. And they said that we are doing approximately 17 million of implants a year. You know what that means? That we are not saving around 17 million of teeth every year. So sorry, I'm a periodontist, so I like to keep teeth alive. In the United States, they do almost half of that amount of implants. So it's a big market for the Americans. In Spain, which is the second country in Europe that places more implants, we're doing around 1.2 million implants a year. And for what I heard in the past 2 days, asking around, they told me that in India you are around 500,000 implants per year. Considering that you're 1.2 billion people in population, you don't do many implants, so that means that you're saving lots of teeth. So ladies and gentlemen, a big applause for the Indian dentists. And we all know that implants work very, very well, because we know that the rate of success is around 98%, okay? And in medium and long-term results are correct only if the implants are correctly positioned, right? And the prosthetic restoration is proper. If we don't follow certain rules, those implants might stay in the mouth, but we cannot say that those implants are well. Why? Because we will see things like this. I know that tilted implants work. Of course they do. But do the restoration of those implants work well? It's very stable. But can our patients really clean that? Most of the time they don't. So we have to be very careful with these type of treatments. And it might probably be better to have the implants in the perfect position than not tilting them to not do certain things. This is not one of my patients. This is, I don't know whose patient. This is something that I found on the internet. Those implants, for sure, are osseointegrated. For sure, and they're in good condition for the dentist who did the treatment. So for him, this is probably part of that 98% of success. But do we want to do this in our clinic? Do we want to do this to our patients? No, we prefer to make the bone grow and put the implants in the right position. But look at this. This is a patient who came to my office. Pink porcelain it's very good in some cases, but not in a lateral tooth with a high line of smile. So we have to be careful. What's the problem? The implant was placed too high in position due to the technique that was used at that moment, that was an immediate placement after an extraction. What about this? This is a 19-year-old girl. She arrived to my office 1 month after this restoration was done. And she was saying that there was something weird that she didn't like, that there was something gray in her mouth. My first question was, like, how do you lose your tooth? And she said, like, Well, I had an abscess, and the dentist decided to extract the tooth and do the implant the same day. I was like, oh, very nice. Looks excellent. Why? Because look at the position of the implant. If you look at the contralateral central incisor, you can see that this implant is probably like 7 millimeters away from the CEJ. So, okay, it's a possible treatment, but it was not properly performed. And actually, he took a double risk because he put 2 implants side by side in the anterior area, which is something most of the people prefer not to do. And what about this one? This is the king of dentists. This is the patient who came to the university with this. And she wanted to have fixed restorations in the laterals. And we were like, and what about the centrals? And she was like, what's wrong with the centrals? So it depends on the eyes of who sees the problem. So ladies and gentlemen, let's remember that the clinician is the person who will determine the position of the implant, considering the ideal position dictated by the final restoration prosthesis. Today, it's not acceptable to place implants just because we have bone. We have to put the implants following the final restorative prosthesis. This is the deal, and this is the way we have to do it. And how do we do this? We have to do an appropriate planning. We have to planify the situation. If we don't have enough bone, we have to obtain that bone, and for that, we have lots of techniques that allow us today to make bone grow, and then we're going to be able to place the implant in an optimal position and perform a suitable prosthesis. I would like to apologize to the audience in the left because I cannot go down and walk that way, and my side is going to the right, but I'm also excited about being with you too, okay? So what is GBR? GBR is the best documented and most used method to increase bone and alveolar defects. And it has some origins that are very basic. Most of the people believe that this is something like kind of new. This is a trend in dentistry. We're making bone grow. We're making tissues grow. But there's nothing new about this. The first references that I found about guided tissue regeneration in the Medline is an article from 1959. People working in traumatological surgery, people working in neurological surgery, and they were already making grow tissues in other parts of the body, but they were making tissues grow. So it's not something new. And for some reason, dentists believe that we're like the people with the best trends, you know? It's like, wow, we're doing the best things. It's like PRP. I don't know how popular it is in India, but in Spain, for a moment, it was like if you were not doing PRP, you were like out of the market. You know, it was like something that you needed to have. Now you enter into the clinics and you see the centrifuge like away in some corner full of dust and nobody's touching it anymore. But because there's definitely some trends. And GBR comes from the principles of GTR in dentistry. Some group of people, very important people, probably the father of the modern periodontics, which is Dr. Linde. He and his team, which were Karen, Neiman, and Linde during the 80s, started to presenting us some information showing us that by being capable of keeping away epithelial and connective tissue cells away from the periodontal defects, we were going to be able to let the periodontal ligament cells grow and give us a fully new periodontal ligament and also alveolar bone in good conditions. From this concept is when we go to what we call guided bone regeneration. Why it's different? Because in the other one, we have to make grow also connective, we're growing periodontal ligament, but when we talk about GBR, we're only making grow bone, okay? So we need only to keep away the soft tissue cells in order to let the bone grow, okay? How do we do this? We do it just by using some membranes, some barriers, physical barriers that are going to keep the non-osteogenic cells away from the defect that we want to recreate. And some people also might think that this is something new, but there's nothing new again. Dr. Sture Neiman in 1991 showed us the first clinical evidence that he was capable of growing bone around the neck of an implant with a small dehiscence. Of course, it's a very, very simple and gentle case, but it was probably the first step that showed us that we were going to be able to make bone grow around implants. So bone augmentation procedures have allowed implant placements in scarce bone areas and have increased the indication for the place of dental implants and becoming routine treatments. We do guided bone regenerations almost every day in our office. But we have to be careful, and we need to know how to start. And to start, the first thing we need to do is select the defect, and of course, we need to understand anatomy. Please remember the shape of the maxilla and the mandible. The red line is pretty much the limits that we have for making bone grow. We cannot go outside the maxilla or outside the mandible, okay? Because the bone will not grow. As you can see here, this would be the maxillary. If I do an extraction, this is probably the residual bone that I will end up having. The red line was the original, and the yellow line is the residual bone. And the right side, if I think about regeneration, this is pretty much the limits that I will have under regular hands. If I go to the mandible, it will be something similar. This is a regular ridge. This is, after an extraction, the residual ridge. This was the original. And if I have to think on basic regeneration, this is pretty much what I will be able or capable of achieving. Maybe 1 more millimeter in height, okay? So when placing the implants, be very careful. Stay inside the anatomical limits. Because if you place an implant, for example, inside the anatomical limits, we're going to be able to regenerate this. But if we place an implant outside the anatomical limits, what will happen? I will do the regeneration, but what will happen with the regeneration in the future? For sure, I will end up losing all that red bone that I put in there. Okay, so remember, there is an anatomical limitation with this. It's like this. If I try to regenerate that bone, I'm going to be capable of doing it. But if I go to the situation on the right, what happened with the distal implant? The distal implant is too away from the limits, and I'm not going to be able to achieve a good regeneration. So be very, very careful. You also have to select the defect that you're going to regenerate, and you have to follow the classification and under the concept of the stability that will give me for the graft and the blood supply that I will have. Look at this. There are some defects in here. In the first case, we have what we consider 2 peaks of bone. We're going to be able to keep the graft in position, so it will grow with no problem. In the second case, we will lose the further we go from the defect, so it's going to be more difficult in the distal part than in the part that it's related to the tooth. And in a thin ridge, we obviously are talking about horizontal growing bone, and it's quite difficult. If we go to situations like this one, we have 2 bony peaks, so it's going to be quite easy. It's like building a bridge, so it's going to be easy to regenerate. But in the second situation, as you see here, by not having a distal peak, it's going to be more difficult, and we will probably start losing bone in the back. And what about after the extraction of a tooth? I have to see if I have soft tissues, and I also have to see if I have bony walls. If I have soft tissue and bony walls, it's going to be perfect for regenerating that alveolus. But if I have only soft tissues and no bony wall, it's going to be a little bit more difficult. But in the third situation, the type 3, it's going to be impossible because I have no bony walls and I don't have any soft tissue. So the procedures I have to think properly because are going to be a little bit more complicated. And that's how we get to the classification of CBER, where you can see we are going to talk about horizontal and vertical, or the combination between them. And according to the millimeters of defect, we can talk about small, medium, or large defect. And it's pretty much the same thing when we go to implants. We have different kind of defects around implants, and we have to understand them. We have the first classification by Schwartz, and then we have a very recent classification that was published a couple of months ago by Alberto Monge, who is part of my team in the university in Barcelona, and also Frank Schwartz, where they start classifying now the defects around implants, not only if they are circumferential, vertical, or horizontal, but also including if it's a small defect, a medium defect, or a large defect. So, ladies and gentlemen, please have a CT scan of the defects, evaluate properly the situations, and then decide what kind of techniques you are going to use. Why? Because there is a lot of evidence, especially these by Dr. Destaola, who is telling us that the amount of walls that we have in the residual defects will be a condition for the amount of bone that we're going to be able to make grow. And if you evaluate the defect selection, is quite easy. The less amount of gingival thickness that you have, the more difficult it's going to be to maintain the membranes cover. The thicker amount of soft tissues that you have, the better possibilities to keep the membranes covered. And the less amount of bony walls that you have in the defects, the less amount of blood supply. So the bone will have no food to eat and maintain. the bigger, the higher number of walls that you have, the most content, the most blood supply, so that it's going to be more predictable to regenerate. Also think about your patients. Not all our patients are candidates for regeneration. We need to have patients that are compliant with the treatment, that comes to our office, that follows our indications, that are non-smokers, okay? That's quite important. And according to that, we also have to decide sometimes. Why? Because if something goes wrong, if the patient smokes 1 pack a day, it's his fault, it's not your fault. But to his eyes, it's going to be your fault, it's not going to be his fault. If he doesn't follow your instructions, whose fault going to be? From our side, it's going to be his fault. But from his side, it's going to be your fault. You are the one who did the wrong work. And what's the first thing that's going to happen? He will go to his neighbor and he will tell him, look, my dentist is very bad. Look what he did to me. And in 3 weeks, everybody will know that you're a bad dentist. But nobody will know that he's a bad patient, because there are no list of bad patients. There should be one on the internet. Sorry, I don't know what happened here. And then we come to what really matters. We have to select the materials. What are we going to do? We have to see, there's lots of people selling lots of material, and we need to know which one we want to buy and why we want to buy that one. So we have to know the characteristics of those materials, which are the goals of my therapy, of course, and what are the indications for the materials that I'm buying. According to that, we have some different membranes and some different type of graft. When it comes to membranes, we have 2 big groups. We have the non-absorbable and we have the resorbable membranes. In the group of the non-absorbables, we have something that is not in the market anymore. This is the Gore-Tex membrane that has 2 versions, the classic and the titanium reinforced. It's a very, very comfortable to use membrane, but with a lot of complications, especially exposure and infection. And that's why it went out of the market, because it was extremely high technically sensitive. Okay? So for that reason, another company got this membrane, modified it, and came out with what we call dense polytetrafluoroethylene, which is the cytoplasm membrane. And what they did is that they improved the limitations that the expanded one had, because they changed the porosity. And this membrane does not get infected by the bacteria in the mouth. So for this, we have a reduced risk of infection. If we go to the literature, I always say it, I always like to show this case. This is the first article published with this type of membrane. It was made in Brazil by Dr. Barbosa. He presented 420 cases. This is just clinical cases. He did extraction, he placed the membrane, not raising a flap, and after 3 months, he found that in all cases, he had very similar soft tissues to the surrounded tissues of the area. And when they did the CT scan, they found that there was a full bone forming under the membrane, showing us that it was very predictable to use with no complications related to this. If we go and see the literature, I have to move this a little bit faster. We're going to see that it's pretty much the same thing using one membrane or the other one today, but lucky for you, the Gore-Tex membrane is not on the market, so you will not have to face the infections that we used to have 20 years ago. For the group of the absorbable membranes, which is the resorbables, we're going to talk about the cross-link membranes and the non-cross-link membranes. I prefer to use cross-link membranes in most of my cases because the barrier effect is a little bit longer than the non-cross-link membranes, but sometimes it's a little bit more difficult to manipulate them. So that's a reason why lots of clinicians prefer to use the non-cross-link membranes. The advantages of using the resorbable membranes is that they have full tissue integrations, just a few complications. The extended barrier function is better due to the cross-link technology, and we also have some predictable bone regeneration. What are the biggest disadvantages of this membrane? That because they're like not so rigid as the non-absorbable ones, it's going to be more difficult to maintain the space of the area for regeneration. Sometimes because your body has to create a reaction to absorb the collagen of the membrane, sometimes you can face foreign body reactions with the use of this membrane. And of course, if we compare it to the non-resorbable membrane, we might see that the amount of bone that we achieve is not so high, okay? When we evaluate of the literature, you will see that the resorbable membranes are as good as non-resorbable membranes when it comes to bone formation. Maybe a little bit less bone is achieved, but when it comes to final results, it's pretty much the same. I want to show you one case. This is a patient who came to me. This is a 2.1. Sorry for the blood on the picture. She had a trauma a few years before. She had a apicoectomy in the tooth, but it did not went well. So we decided to extract the tooth. For that, I normally use some acrylic small stent before the extraction. You will see why. I locate the stent. I do the extraction. You can see very clear the line of fracture in this tooth that was not that had no clinical complications. This is the situation after the extraction. We can see a fully conserved alveolus. This is the preparation of the membrane. I did Dr. Cho technique, which is the ice cream cone technique. In this case, why do we trim it like this? You will see it. Because I place what it is, the cone of the ice cream inside the alveolus. I fill the alveolus with, in this case, some allograft. And then what I do is like what it should be, the ice cream bowl. I bend it and I cover the alveolus. So my graft is protected. Can I leave this membrane exposed? Of course I can leave it exposed. Nothing will happen, okay? The results are gonna be identical. What do I do after? I take the same tooth of the patient, I remove the root, and with an orthodontic wire, I did some bonding in the palatal side using that little stent that I prepared with the acrylic, and I locate the tooth in the exact same position. Then I check the occlusion, and I leave my patient like this. After 6 months, you can see here the CBCT scan cuts. We can see that it's a complete bone formation in the area for the placement of the implants. This is the clinical situation of the patient. It actually looks better than before. We removed the temporary crown. This is the design of the flaps. I normally leave the attachment to the contralateral tooth. This is the placement of the implants around 1.5 to 2 millimeters from the CEJ of the adjacent tooth. And from an occlusal point of view, I like to stay in the area of the cingulums because I normally work with screw retained prosthesis. Then we close the area. I don't like to do immediate loading, especially on bone that I regenerated, because I want to be sure that everything heals properly. We can see here that we change the situation of the temporary. This patient had no problem with the aesthetics. This is the x-ray after the surgery. This is the 15 days some clinical situation. Look at this after 4 weeks. This is pretty much how it looks. It looks like the soft tissues are fine. It's time to do the loading. It's been 3 months after the placement of the implant. Look at the health of the soft tissue. Everything looks fine. We have a very good height for the contour of the gingiva. We have very good volume in what the buccal side means. So we did a temporary screw retained crown using the same tooth of a patient and modifying it a little bit with some composite. And because this is a PEEK plastic, we don't see it properly in the x-ray, but the implant looks very, very well. This is after 3 months with the temporary crown. Looks very nice. And we go and start working with the final restoration. This is the final restoration that we did in our patient. As you can see, pretty much the contour of the gingiva looks quite natural. Actually, the crown looks better than the natural teeth of the patient. She didn't want to have a veneer or any widening, and you will see why. This is 6 months after the placement of the crown. Look at the gingiva, completely healthy. And this is after 1 year. Still looks perfect. Now you know why she didn't want to have any modifications of the other teeth, because it was only the area that I was working that looked good. The rest of the mouth looks terrible. But she was not worried about that. Look again, a close-up of the area, and it looks still the same. And this is the situation 5 years after. This is my patient now. Look at the implant. I continue saying that it looks better, the implant, than the natural tooth. on the other side. So this is quite predictable and quite easy. And look at the X-ray from 2013 to 2018. It looks pretty much the same. Why? Because we did a good planification, we had enough bone, we placed the implant exactly where we wanted, and my patient is coming to the supportive therapy visits, and we are keeping it clean and absence of inflammation. When it comes to the other group of membranes, we have the, we can use sometimes also a cellular dermal matrix. You will soon in the market have one that is made from porcine origin, which is very, very good, and it will give you an extra addition, and it's that it will integrate to the soft tissues of your patients, and you will end up gaining more thickness of the soft tissues. It has the same effect as a barrier for the graft, and there is some evidence showing us that this is possible to achieve. And I want you to see this case. This is a patient with a very advanced case of periodontitis. He's only 40 years old. So we decided to save some of his tooth. As you can see here in the CBCT, some of the tooth were impossible to save, like number 12 or number 11. So we decided to do the extractions and do some regeneration. And instead of using regular membranes, I decided to use, in this case, a cellular dermal matrix to obtain a little bit more thickness of the soft tissues. In this case, we mix some xenograft with some allograft. We cover it with a cellular dermal matrix. This is the other side. Sorry for the pictures. It doesn't look very well. This is the premolar areas. And this is the final closure of the whole maxilla. And we waited around 4 weeks, and this is the result. As you can see, it's very, very stable in what height means. And from a horizontal point of view, we can also see it looks very, very good. This is the CBCT. In the 1.6, I ended up needing some osteotome techniques to make a little bit of elevation of the sinus, but in the other locations, I was capable of placing implants under regular conditions. This is the reach after the regeneration, and this is the other side. And here you can see a little bit of the placement of the implants, how they look, that they are in the right position. Implants again. X-ray of the implants. This is the panoramic view of the implants. Those molars were still for extraction after the end. And this is the final restoration of the patient. As you can see, there's some plaque present, so now you know why he had some periodontal problems. It is impossible to make him clean properly, but at least we solved the situation with a good regeneration and the placement of the implants in the right locations. And this is the smile of my patient at the end of the treatment. So, which is the best membrane? There is no best membrane. They all work properly. There are some works showing that. This is in this article that is presented also by some people from my university, Dr. Jordi Caballé, they end up saying that we can choose the membranes according to factors as space maintaining, the cell occlusiveness, the handling, and the bioactivation friendly. So depending on what you're doing, you have to choose one type of membranes or the other type of membrane. Other articles have said that if we need to do vertical regeneration, we prefer non-resorbable membranes. And if we're doing horizontal regeneration or socket preservation, we can go straight for resorbable membranes because it will give us less complications. And now let's go for bone graft to finish. And let's see if I'm capable of doing it in 6 minutes. We have different type of bone graft. We have the autogenous bone, which is probably the gold standard and what we prefer. Then we have some allograft like FDBA or DFDBA. Then we have the xenograft that come from different species, mostly bovine or porcine. And then we have the alloplastic materials like tricalcium phosphate. I don't use tricalcium phosphate. I normally go for xenograft of bovine origin. And I had this small talk with the group that was with me in the hands-on 2 days ago. And I heard that, well, I was aware that cows were sacred animals in India, but they told me that you were still using xenograft from bovine origin, so we decided that the bovine graft is a sacred graft, so from now on it's a good way to sell that to your patients. According to the properties of the graft, we can divide them into osteogenic, osteoinductive, and osteoconductive if they are capable of generating bone by themselves or only guiding the bone to grow around them. For what it comes to bone allograft, it has some very good advantages. It's that it could be osteoconductive and some of them considered osteoinductive too. It has very good antigenicity. You have availability as much as you want. You can buy tons of bone if you need them. It's available in India, I heard, so you can use it with no problems. There is no morbidity from a second surgical area. It's very similar to the surface of the autologous bone of your patient. It's very stable and easy to handle. What are the disadvantages? Probably the security. Lots of people is afraid of receiving a graft that comes from another human, but I always say the same thing. You trust the cow, you trust the pig, but you don't trust other humans. And who took care of the cow and the pig? So, for sure, when they have to analyze the donors, I'm sure that they do most screening on a human donor than on a cow or a pig. So I prefer, actually a few months ago, I did a graft on my mom and I went for an allograft, okay? And some people says that it's unpredictable, the resorptions. We have two versions. We have the mineralized and the demineralized versions of the bone. It's pretty much, according to the literature right now, there's pretty much no difference between one and the other one. What you will see is that a mineralized, of course, is going to be a little bit more difficult to resorb. The non-mineralized is going to be less difficult to resorb. So if you analyze in a period of 3 months, if you use a mineralized version, you will have some more residual particles. And if you use the non-mineralized version, of course, that you will have less residual particles. It's very easy and simple to think. But at the end, after 4 to 6 months, both of the grafts will be completely resorbed and substituted by nature bone from our patients. According to the security, don't worry, ladies and gentlemen, we can use this very, very, very safe in our office. There are different reports. One of them says that 1 in every 2.8 billion are the possibilities of suffering. The other one says that it's 1 in every 1 million. Up until now, if you go and check the literature, there is no reports of any kind of contagious by the use of this type of bone. And if you think again, cortical versus cancellous is pretty much the same thing as demineralized versus non-demineralized. The cortical bone is more difficult to resorb, so it's going to last a little longer, and the cancellous bone is softer, so it will resorb faster. But they both will give you pretty much the same stability. My recommendation, use a mix. When you order the bone, normally order for a mix of cortical and cancellous bones. Most of the companies have them, okay? If we analyze the literature, you will see that there is no difference by using one or using the other one. As I said, that is that cancellous resorb a little bit faster. This is a good thing. Everybody's in a hurry, and so am I, because I only have a few minutes to finish. How long do I have to wait when I do an allograft in my patients? This is a good thing, because if I do a xenograft, I normally have to wait 6 months. But if I do an allograft, literature has proved that after 3 months, I can re-enter the area and I can go and place the implants. So if you're in a little bit of a hurry, go for an allograft and don't go for a xenograft. If you want to maintain that bone or the volume, it's better to use a xenograft. But if you are not in those situations because you have a very content defect, go for the allograft. Let's see another case. This is Elena. Pretty similar case to the other one that I showed at the beginning, but in this case it was an external resorption of the central incisor. It was impossible to save. We did the extraction. We follow exactly the same procedure. In this case, we follow, instead of placing the membrane in the buccal, I did it in the palatal. This is an allograft, cortical and cancellous, sutures. This is the situation after 15 days for the removal of the sutures. We can see here around 1 month after how it looks. I still have all the buccal volume. This is the clinical situation from a frontal view. And this is the CBCT scan where we can perfectly see the difference between the native bone and the regenerated bone. We go for the implant placement. I only have 1 minute. And we place the implant. You can see that it's in the right position. And this is the final restoration. Look how it ended up after 3 years. And you can see from 2016 to 2019. And for bone xenograft, pretty much the same thing. It's compared to the allograft. Today it's pretty much the same thing. but the only thing that we don't know if it's completely resorbable. I have to say that it is not. There are reports that after 12 years, we can still find some particles inside, and so is the literature about it. But they tell us that the potential of the xenograft is that they seem to have less shrinkage compared to the allograft when we use it. So if you want to maintain the stability of that bone, sometimes it's better to use, or if you have bigger defects, go for this. Let's see one more case. This is Jorge. In this case, wow, that was the fastest minute of my life. He has a very thin ridge. Let me show you this case and we're over. This was very cortical bone, so I drill, I prepare the bed for the implant. I did some decortications in this case. This is the placement of the implant. What happened here? Sorry, I was fast and run out of time, and now okay. Here. And we will.
Doc, you can take another 5 minutes.
Okay, thank you. This is the bone graft, I'm sorry. This is the bone graft, and you can see if it's too red, but you can see the membrane in there. We covered sutures. This is the implant in placement. And I'm sorry because of the time, I will not show you the final restoration, but it ended up quite well, but this is the result. And now one final case that I want to show with you and share. This is Nerea. This patient came to the office. She had a trauma when she was younger. She didn't want to have orthodontic treatment. We fight with her. We ended up having orthodontics. This is when she arrived to this point, she said, like, I don't want to continue with the orthodontics. I'm tired. She didn't care about the open bite. So we were supposed to put an implant in the lateral missing teeth. This is the CBCT scan. It was a scarred bone, so actually very difficult to take pictures on this patient. This is the horizontal view. This is the design of the incisions. We open, we place the implant inside the anatomical limits. We cover the implant, as you can see here, with a bone graft, in this case a xenograft. This is the membrane. We close. For this patient, I decided to wait 6 months. This is the extraction of the sutures. We took advantage of the orthodontics to maintain the pontic in there. This is the situation. This is the provisional, the screw retained provisional of the patient. And this is the final result. I cannot show you more because this is the last picture that I took like 2 weeks ago. So we can see that it was very predictable and it looks very, very natural. I'm still we're modifying the central incisor prosthesis because it has a little bit of retraction. And this is the initial 6 months, 2010 and 2019 for this patient. Okay? The security, be very, very safe. No mad cow disease, no problem. This is a sacred graft, as I said before, and the risk of suffering something by the use of this graft is compared of dying from a lightning strike, a tornado, or a similar event. So don't worry about using this. And now, I want you to know that the survival of the implants is quite high. We're saying that the placement of implants on regenerated tissues is around 95.8% survival. Some other article says the same thing and says that it's over 95%. So be sure or feel safe when you regenerate and do implants in these areas because they are as stable as the rest. For the conclusions, I want you first of all to take a very extensive evaluation of the situation of your patients. What are the clinical implications for the patients and for the dental teams? We all need to be trained into what we're doing. We have to choose properly the procedure according to the evidence, the skills of the clinicians, and the expected results. And of course, be very careful with the biomaterial selection. And the most important thing, not for my presentation, but for all the presentations and all the meetings that we go around the world, there are no cooking recipes when it comes to procedures in dentistry. So learn a lot because all situations are different, and we need to have the particular tools for each of the situations. So India, dream big, set your goals, and take actions to make better treatments. Thank you very much. Dhanyavad.